Hello everyone. In this season, we are going to study hepatic diseases. First, let's talk about bacterial liver abscess. When a patient suffers a generally bacterial infection, intra-abdominal infection in a particular, the bacteria will invade the liver, and if the patient's resistance to the bacteria is weak, a liver abscess may occur. Patients with underlying medical condition, especially diabetes, are the susceptible group of this disease. Bacteria may invade the liver through biliary tract, portal vein, hepatic artery. The biliary tract is the main route for causing a bacterial liver abscess. In addition, bacteria in an infectious lesion focus adjacent to the liver may invade the liver through the lymphatic system. In this case of an open liver damage, bacteria can invade the liver directly through the wound, leading to infection and then a liver abscess. The pathogenic bacteria of bacterial liver abscess are mainly Klebsiella, Escherichia coli, and anaerobic Streptococcus, Staphylococcus, etc. The volume of a solitary liver abscess sometimes may be very large. The diameter of multiple liver abscesses could range from several millimeters to severe centimeters, and several small abscesses can also be combined into a large one. Next, let's have a look at the clinical manifestations of bacterial liver abscess. This disease generally occurs abruptly, and the main symptoms include shivering, hyperplasia, hepatalgia, and hypomegaly, and a temperature as high as 39 to 40 degrees centigrade. It is often accompanied by nausea, emesis, decreases of appetite, and weakness. A dull pain or swelling pain may be persistent in the hepatic region, sometimes accompanied by a referred pain in the right shoulder, a percussion pain in the right lower chest and the hepatic region, and a tenderness in swollen liver. When an abscess is at an interior superficial location below the liver, it may be accompanied by tension in the upper abdominal muscle and local apparent tenderness. A massive liver abscess may make the right hypochondrium full, sometimes even local raised, and local skin may be red and swollen. Jaundice may occur in a serious case with complicating obstruction of the biliary tract. An abscess in the right lobe may penetrate through and become a subdiaphragmatic abscess, or may penetrate to the right chest, while an abscess in the left lobe may occasionally penetrate into the pericardium. When an abscess penetrates to the abdomen, acute peritonitis may occur. In a few cases, abscesses may penetrate through blood vessels and the biliary tract wall, leading to massive hemorrhage, which would be drained from the biliary tract. The clinical manifestation is upper gastrointestinal hemorrhage. In respect of lab tests, the WBC and the neutrophil percentage of the patient would increase. The transamin, alkaline phosphates, and C reaction protein would increase, and the blood sedimentation will prolong. Chronic patient may also show the anemia and the hypoproteinemia. In respect of the imageological examination, the ultrasonography can be used to determine the location and size, and for a positive diagnosis rate as high as over 96%, it is the preferred examination method. In an X-ray examination, we may see the diaphragm muscle is raised by an abscess in the right lobe of the liver. The liver shadow is increased, or there is local lymph. Sometimes reactive pleurisy or pleural effusion may occur on the right. In an X-ray barium meal examination of abscess in the left lobe, we may see compression or displacement of the lesion curvature. When necessary, a CT scan may be carried out. At the time of diagnosis, we may diagnose the disease according to the medical history, clinical manifestations, ultrasonography, and X-ray examination of the patient. When necessary, a diagnostic puncture may be carried out the spot of the hepatic region with the highest level of tenderness or under the guidance by the ultrasonography, and the defined diagnosis can be made if pus can be extracted. Moreover, a differential diagnosis of this disease versus amoebic liver abscess, right subdiaphragmatic abscesses, and hepatic carcinomas shall be carried out. Next, we will talk about the treatment of this disease. Bacterial liver abscess is a serious disease and must be diagnosed and actively treated at the early stage. First, provide sufficient nutrition through the general supporting therapy to correct the fluid and electrolyte disturbances, and if necessary, transfuse small volumes of blood and plasma for multiple times to rectify the hypoproteinemia and reinforce the immunity of the blood. Large doses shall be used in the antibiotic treatment before determination of the pathogenic bacteria. Broad spectrum antibiotics may be empirically used, generally third generation cephalosporin combining metronidazole or ampicillin, aminoglycosides combining metronidazole, etc. Then select the effective antibiotics according to the bacterial culture and drug-sensitive risk resulting of the pus or blood in the abscess cavity. For individual abscesses with the diameter of 3.5 cm, the ultrasound-guided percutaneous transhepatic catheterization and drainage may be applied. On the second day or a few days after the catheterization and drainage, isotonic saline may be used to slowly flush the abscess cavity, and then antibacterial agents shall be infused. Extubation may be carried out when the flushing fluid becomes clear and the abscess cavity is significantly decreased in the ultrasonography, while incision and drainage is applicable to large abscesses labeled to penetration are already penetrated into the thoracic cavity or the abdominal cavity. Biliary abscesses in the left outer hepatic lobe which are labeled to contaminate the abdominal cavity after penetration, and patients of chronic liver abscesses. The common surgical method nowadays is the laparoscopic incision and drainage, and the laparotomic incision and drainage is seldom practiced now. During the operation, care shall be taken to properly isolate the protection and abdominal cavity and other organs to prevent the pus contamination. Place porous rubber hoses in the abscess cavity for drainage, not during the operation. That If an abscess has already penetrated to the chest cavity, drainage shall also be made for the chest cavity. For liver abscesses caused by infection of the biliary tract, drainage shall also be made for the biliary tract. In the case of a hematogenesis liver abscesses, cavity treatment shall be carried out for the primary infectious lesion focus. For chronic localized thick wall abscesses of a long course, resection of the hepatic lobe may be carried out. That is all for bacterial liver abscesses. Thank you for coming to the class. See you.